Hi, I am Sherry Girolf, Physician Assistant. I'm going to be talking today in part 2 of our Physician Assistant Domestic Violence course about child abuse and elder abuse. This slide set has been adapted from Dr. Jennifer Harrington. I'd like to thank her. I have no financial gain from this lecture, but I do want to let you know that I am a salaried employee at Lincoln Memorial University as principal faculty, and I am currently the FAPA Vice President as a volunteer. My name is, again, Sherry Girolf. I'm a certified physician associate with more than 27 years of experience in primary and specialty care. I have worked in internal medicine, acute care, hospital medicine, skilled nursing facilities. I completed my Doctor of Medical Science in December of 22. At that time, I was given the opportunity to join Lincoln Memorial University as principal faculty in January of 23. I've been an active volunteer for Special Olympics for several years, and I am the mother of 4 boys that keep me very active. I just want to let you know that some of these topics are difficult to discuss, and there may be content or images that are hard to see. The objectives for today, we're going to be going over the statistics for child abuse. We're going to define what constitutes child abuse. We're going to review risk factors. We're going to describe the history and physical exam findings suggestive of child abuse and describe the appropriate steps in the evaluation of suspected child abuse. We're also going to describe the appropriate steps in the intervention and reporting of suspected child abuse. There is a clear connection between domestic violence and child abuse. 30 to 60% of families in which either there is maltreatment of a child or adult domestic violence is occurring, it typically means that the other form of violence is occurring. So if there's child maltreatment, there's most likely adult domestic violence, or if there's adult domestic violence, there's often child maltreatment. Child abuse and intimate partner violence are more likely to occur when there are difficulties in the household. So if there's poverty, substance abuse, mental health disorders, or social isolation, like when we went through COVID, there was a tremendous upswing in abuse cases. Key facts that we want to make sure we discuss today, in addition to our objectives: violence against children includes all forms of violence for people under the age of 18. It's estimated globally that 1 billion children from the ages of 2 to 17 have experienced some form of violence in the last year, whether that be physical, sexual, or emotional abuse. Experiencing violence in childhood has a lifelong impact with their health, their well-being, and there's evidence from around the world that shows that violence against children can be prevented. So this is a preventable disorder. I want to make sure that we review from our previous lecture: intimate partner violence or domestic violence involves physical, sexual, emotional violence by an intimate partner, or it also can include an ex-partner. And although males can be victims, they are disproportionately, this affects females. It commonly occurs with girls within child marriages if they're forced to have an early marriage. Also among romantically involved but unmarried adolescents, and this is often called dating violence. 3 million cases of child abuse are reported annually in the United States, and children under the age of 3 have the highest rate of child abuse. 1,500 children die annually in the United States due to abuse or neglect. In Florida, approximately 45 million children will be exposed to violence during their childhood, whether that be seeing violence or having violence against them. Approximately 10% of children are exposed to domestic violence annually. 25% are exposed to at least one episode during their childhood. Those are crazy statistics. 90% are direct eyewitnesses of violence. Males who batter their wives also batter their children 30 to 60% of the time. Children who witness domestic violence are at increased risk for dating violence and have a more difficult time with partnerships and relationships, and also later in life parenting. Children who witness domestic violence are at increased risk for post-traumatic stress disorder, aggressive behavior, anxiety, and other mental health disorders, and in addition, substance abuse increases in this population. Children exposed to domestic violence often become victims of violence. Again, dating violence is increased in children who have been exposed to domestic violence. And I believe that's because they don't understand proper interactions with others. And so they're more accepting of violence when it's acted on them. Children who witness and experience domestic violence are at greater risk for adverse psychosocial outcomes. 80 to 90% of domestic violence victims abuse or neglect their own children. Abused teens usually don't report. Individuals 12 to 19 report about 1/3 of crimes against them compared to 1/2 in older age groups. And 7% of domestic homicide victims in Florida were killed by their parent. Risk factors for child abuse include, for the caregivers, those who abuse drugs and alcohol, in a lower socioeconomic status, have mental health issues, have been abused themselves in the past, young, single, low level of education, if there's family discord in the home, when a child has a disability or a behavioral disorder like severe attention deficit or oppositional defiance disorders, or if there's been previous domestic violence in the home, that increases the risk for child abuse. The impact of violence throughout the years results in death and leads to severe injuries. It can impair brain and nervous system development, results in negative coping skills later in life. It causes health risk behaviors, leads to unintended pregnancies, can contribute to a wide range of non-communicable diseases, and it can impact opportunities or future generations. It often affects and causes a higher risk for high school dropout or school dropouts. A 4-year-old girl presents to her pediatrician with her mom for a school physical. On that exam, the pediatrician notices multiple bruises on the buttocks, a small circular burn mark on the upper arm, and the child seems lethargic. When asked, the mother says the girl is clumsy and has no explanation for her injuries. Because of the lethargy, a workup is done. Laboratory findings are normal. She has a chest x-ray again because of the lethargic behavior, and a chest x-ray shows a right-sided rib fracture. Now that prompts additional workup, and upon additional workup, a CAT scan is completed. And that CAT scan reveals evidence of a head trauma. You can see where the arrow points, a subdural hematoma, and that is evidence of child abuse. A patient encounter is where you're going to pick up on these clues. When you were discussing with the parent, what in that example that we just talked about, is concerning to you. The mom just says the child is clumsy. When the physical injuries have no history of trauma, that's something that you want to be concerned about. When the history doesn't explain the injuries, the girl is just clumsy. When the history of injury changes over time, so mom first says she's just clumsy, but then later when you ask again, the story changes. If there's history of self-inflicted trauma, again, the girl is just clumsy. Or if there's a delay in seeking care. I want you to watch this video. This is about the 10-4 Faces P. This is a tool that can be utilized.
Hi, I'm Dr. Mary Clyde Pierce, a pediatric emergency medicine physician and injury researcher at Ann and Robert H. Lurie Children's Hospital of Chicago. Today I'm excited to tell you about a tool named 10-4 that can improve our ability to recognize when a child or infant has been abused. Several years ago, I noticed that the bruising on abused children looked very different than children who were bruised by accidental injury or from regular play. This makes sense because having an accident injures your body differently than the injuries you get from maybe a physical assault. These unusual bruises really stood out to me because I noticed that they often occurred on children prior to a serious or even fatal injury from physical assault. These atypical bruises were often overlooked by family members, daycare workers, social workers, or medical providers, likely because bruises are so common and usually insignificant clinically. But like a canary in a coal mine, these unusual bruises can serve as a warning or a signal of what's to come. Specifically, our research team noticed the bruises were unique. They occurred in different locations on the body, such as the ears or the jawline. Some of them occurred on young infants, which didn't make sense for babies who aren't even yet crawling. The team first worked with nurses and a biostatistician out of the University of Louisville and gathered pilot data on patients in the intensive care unit there. This work led to our initial bruising clinical decision rule named 10-4. 10-4 is a rule that applies to children under 4 years of age with bruising. The TEN acronym stands for bruising to any of the following regions: torso, ear, or neck. And the 4 stands for any bruising anywhere on the body of an infant 4 months of age and younger. The bruising clinical decision rule, 10-4, is why we're bringing attention to this on October 4th, which is also 10-4. After moving to Chicago, our research team continued this work with the wonderful support from Lurie Children's. We were able to obtain a major grant from NIH to validate our bruising clinical decision rule that differentiates abuse from accidental injury in young children. This grant allowed us to collaborate with other children's hospitals as well, including the University of Louisville and Comer Children's Hospital at the University of Chicago. After years of research, the final rule we developed is called 10-4 FACES P. This latest clinical decision rule is both sensitive and specific for identifying young children who are suffering abuse. This is promising for many reasons, but especially because it may allow us to see when things are going wrong before it escalates to permanent injury or to even death for a child. Like the canary in the coal mine, being able to see these warning injuries before it escalates is a critical key for the prevention of child abuse. So what does the acronym 10-4 FACES P stand for? If a child under 4 years of age has bruising to the 10 or torso, ears, or neck, torso, ears, or neck, or 4, meaning bruises anywhere to an infant 4 months of age or younger, or FACES, which stands for frenulum, which is the little soft tissue inside the gum, angle of the jaw, cheek, the fleshy part, the eyelids, or the subconjunctiva, which is the white part of the eyes, or a pattern to the bruising, such as a slap mark or a loop mark. Noticing the little things, like a bruise, allows us to potentially make a big difference in the life of a child at risk of abuse. Thank you for your time and attention to this work. The first step to prevention of further harm for these children is often just being able to see when things are starting to go wrong and then helping. Thank you.
This is a tool that can be utilized. This is something that you can present to other members of your faculty, just as a reminder of what to look for when you see bruising. Child abuse, the history is the key to the diagnosis. Diagnosis is based on history that is inconsistent with clinical findings. You want to approach the family in a non-accusatory manner. The history may be absent. You may have partial story. It changes over time. It just doesn't fit. It's illogical. It's improbable. It's, crazy to think that with all the injuries that young girl had, that she was just clumsy. If there's any discrepancy in the history, you should prompt a consideration of reporting to Child Protective Services. Child Protective Services is mandated by state law to investigate reports of suspected child abuse, whether it be through social services or law enforcement officers or even through a home visit. Important social history questions. You want to make sure you know who lives in the home, who are the other caregivers in the home. Are all of the child's caregivers in good mental health? Does anyone have mental disorders, anxiety disorders? Is there financial instability or discord in the home? Is there any history of domestic violence in the home or substance abuse? Do caregivers have a prior history of being abused in childhood or as an adult? And have there been any previous involvement with social services or law enforcement in the past? Physical exam findings, you might see multiple injuries. This might include abrasions, bites, bruises, burns, any type of dental trauma, fractures, lacerations, ligature marks or scars, lacerations in that frenulum that attaches the lip, injuries that are in multiple stages of healing. So you have some bruises that, bruises come in different colors. So you may see some in purple, then you may see some in yellow, and that's showing multiple stages of healing, whether it be also lacerations in different stages of healing. Patterned bruises is something you want to look for. That might indicate a belt mark or pinching. anywhere in the soft tissue areas, or there may be bruises in an infant that doesn't even crawl yet, and that's unusual. You can't just say that they're clumsy. These are marks that would be really essentially pathognomonic for abuse. Any head contusions in an infant, orbital swelling, bleeding of the ears, bite marks, any contusions to the jaw, which would be rare in a fall, multiple fingertip contusions on the chest wall, so you can see where there's handprints essentially, any type of open handprint from like being spanked overly hard, spanked at all, lash marks like from a loop. You may see contusions across the nasal bridge from being, backhanded, a black eye, which is unusual in a child or an infant, any lip lacerations, any type of grab marks on the arms, contusions in the abdominal wall, or belt marks, like lacerations from a belt across like the back or bottom. The most common physical abuse injuries are typically bruises, burns, any fractures, head trauma, abdominal injuries or trauma, or infant or baby deaths should always be investigated for child abuse. Physical exam findings that we talked about, belt marks, any scalding injuries, obviously a bite mark would trigger, cigarette burns would be a trigger, but you can see on this child where there's you can kind of see the linear marks, that is from a belt, slap mark across the face, or that injury to the frenulum. Burns that are pathognomonic for abuse would be a stocking glove distribution, where the hand has been stuck in water or scalding or burning. Immersion burns to the buttocks. Any branding burns like a cigarette burn you see in the upper picture. Any burn that would be like a curling iron burn, which is a linear burn. The absence of splash marks. If a child's been burnt and it was just from a splash, they pulled a pot down on them, you would see marks that included splash marks, not just something like an immersion burn. Shaken baby syndrome. Head injuries is the leading cause of mortality from physical abuse. This mostly is in crying babies, and typically men are the abusers. Usually younger than 6 months, the baby presents to the clinic. They may have seizures, they're lethargic, apnea, they may be in a coma, you might see retinal hemorrhages. 25% of these cases are misdiagnosed as some other form of injury. Child abuse emergencies include any infant with bruises in the head, face, or abdominal area, any baby with shaken baby syndrome symptoms, burns or fractures, all must be treated as an abuse emergency. Any child with abdominal trauma, those stocking glove burns or pattern burns, burns in the genitalia, or any burn that's unexplained, burns that don't show splash marks. Signs of recent sexual assault. Most collection kits must be done within 48 to 72 hours, so that is the importance of getting these diagnoses, or at least having it in your differential diagnosis. Fracture diagnostics. You want to order a skeletal survey. If there's any suspicious fracture found, like this bucket handle fracture, you would want to order a skeletal survey. Radiologic findings that are common in abuse are bucket handle fracture of the long bones, spiral fractures of the extremities, rib fractures, anything in the spinous process in a young child, or fractures with multiple stages of healing, or multiple fractures. One time you see a wrist fracture, then a collarbone fracture. This is not just a clumsy child. This needs to be investigated. Abdominal trauma diagnostics. You want to make sure to get an abdominal CT as the preferred diagnostic test if you're concerned about abdominal trauma. Any hollow viscous injuries is pretty much pathognomonic for abuse unless there's a known accidental trauma. Simultaneous injury to solid or hollow organs is almost always abuse. Head injury diagnostics. You need to get a head CT or MRI as the diagnostic test for a suspected head injury. Subdural hemorrhages in the absence of any known accident, like they had a car accident, is something that you need to consider abuse. You can see in these two scans a subdural hematoma in both the top and the lower images there. Differential diagnosis for child abuse. So there are times when this is an accidental injury. You may consider this child in the picture shown that they have belt ligature marks, but that is, possibly a Mongolian spot. You may see erythema multiforme, a Stevens-Johnson syndrome, and you may think that was where a child's been scalded. There could be hematologic disorders or genetic disorders like Ehlers-Danlos, infections such as, again, the staph causing a scalded skin syndrome, or they may have multiple fractures because of osteogenesis imperfecta. So those things need to be ruled out if you're concerned about child abuse in these types of scenarios. Sexual abuse, and that's engaging developmentally immature children in sexual activities that they do not fully comprehend and they cannot give consent for. Any exploitation or enticement of a child or adolescent through the internet or social media, that's asking a child to send pictures. It can include incest, sexual abuse, rape, pedophilia. This can be fondling, oral, genital, or anal contact, any form of intercourse or penetration, exhibitionism, voyeurism, any type of exploitation or prostitution, or again, any involvement with a child with pornography, including asking a child to send nude pictures. The clinical presentation, the child may appear withdrawn, they may have aggressive behaviors, they may be angry, depressed, they may be hypersexualized or have hypersexualized behavior. So these are young, 13, 14-year-olds that have hypersexual behavior. There's usually no physical signs on the outside for sexual abuse. So that's why this is such a difficult diagnosis to make. Important sexual abuse questions. When the diagnosis of sexual abuse is made by history, you want to take a careful history from all the caregivers, and you want to make sure it's done separately. You want to ask open-ended and non-leading questions for the child or anyone you're interviewing. If the child is too young, you may ask them to draw a picture. You want to ask about medical issues related to the abuse, such as timing, symptoms such as bleeding, discharge, genital pain, who was involved in the scenario. Again, pictures is something that can be very helpful. This is an example of pictures drawn by a 6-year-old child after abuse. You can see that these are difficult to look at, but this child may not have been able to tell you what was going on, or may have been frightened to tell you. But when asked to draw a picture, it becomes very clear that this child has been abused. Physical exam findings of sexual abuse. There may be external genital or rectal lesions, contusions or bruises on the inner thigh, injury to the oral mucosa, the breast or thighs area. This is when you are able to do a speculum exam, there may be semen found. A REAP kit needs to be collected within 48 to 72 hours. That's why it's important to identify this as soon as possible. You may see STIs in a post-pubertal children and younger children. Transmission is almost none. You may see pregnancy in an adolescent child, genital or rectal erythema or rashes, irritation that's not suggestive of any other causes, could suggest sexual abuse in the absence of any history or behavioral changes that might suggest some other condition or story. Emotional abuse or psychological abuse is any verbal abuse, which is most common, rejection of the child, ignoring, criticizing, isolating, even terrorizing the child. It may present as the absence of parent-child attachment. It's in the inability to recognize and respond to an infant or child's needs, or you may see that as a failure to thrive. Neglect. The most common form of abuse is neglect in 78%. Failure to provide food, clothing, shelter, or a safe environment could be neglect. Failure to respond to a child's needs, which can result in developmental issues, or like we discussed, failure to thrive. A minor being allowed to engage in harmful behavior, like, for example, you allow 12-year-olds to drink alcohol. Leaving a child unattended. In some states, leaving a child under 13 home alone is considered neglect and child abuse. So you want to make sure you understand the state laws. Fictitious disorder imposed by another. This is previously called Munchausen syndrome. This is a form of abuse. I wanted to show you an example.
There's no doubt you've probably heard that term before, Munchausen syndrome by proxy. What does it mean, and how can you tell if it's happening? Natalie Haddad explains.
Munchausen syndrome by proxy is a complicated disorder. Simply put, it's medical abuse when a child or someone in another person's care is put through unnecessary medical treatments because their caretaker lies about the victim's health and symptoms. And we're talking about it now as we look deeper into the case of Jessica Gasser. But it's happened before in DFW. One of the more recent cases involved Dallas mother Kayleen Bowen. In 2019, she was arrested for medical child abuse or Munchausen syndrome by proxy. She was sentenced to 6 years for subjecting her son to hundreds of unnecessary procedures and surgeries. So what are some of the red flags you should know? Doctor shopping is a big one. When a caretaker goes to multiple medical facilities, sometimes in different states, to get procedures done. Another, the caretaker might insist on a diagnosis that tests prove to be false. A couple more things. If a victim's symptoms are only present when they're in the care of a specific caretaker, or if the caretaker shows no relief, even when they get good news from the doctors. Now, these are all red flags for not only medical professionals, but for people like you and I to be aware of and report it when we see it. I'm Natalie Haddad.
There's no doubt.
So this is medical child abuse. It previously was known as Munchausen syndrome by proxy. It is now considered fictitious disorder imposed on another. A caregiver creates symptoms or illness of a child and seeks medical care. It presents as frequent unexplained illnesses. Apnea is one of the diagnoses that's pretty common. Dehydration from induced vomiting or diarrhea. There may be sepsis when a contaminant is actually injected into the child. You might see a change of mental status, GI bleeding disorders, and seizures. These cases are complicated and they can be fatal. Again, as you saw in the video, it could be, you may recognize it by doctor shopping and that they don't accept that the child is healthy when you give them the good news or a good diagnosis. When you see child abuse or there's any concerns, you want to call the child abuse hotline. The number is listed here. You can call the local child protection agencies and notify the police department. Chapter 39 in the Florida statute mandates that any person who knows or has reasonable cause to suspect that a child is abused, neglected, abandoned by a parent, a legal custodian or caregiver, or another person responsible for the child's welfare shall immediately report such knowledge or suspicion to the Florida Abuse Hotline and the Department of Children and Families. Florida is a mandatory reporting state. This is information about mandatory reporting. Again, Florida is a mandatory reporting state. If you see anything that you feel is concerning, you must report. Inspire is strategies to help prevent child abuse. It's 7 strategies that we could consider. So implementation and enforcement of laws. So example of that would be banning violent discipline. Norms and value changes, so examples, altering norms that condone sexual abuse of girls or aggressive behavior among boys. Create a safe environment, such as identifying neighborhood hotspots for violence and make sure you address local causes so that you can help prevent these unsafe areas. Parental and caregiver support, make sure parents are given training for especially young first-time parents on how to care for their infant child. Make sure that they have the support that they need. Income and economic strengthening, such as microfinancing or gender equity training. Response service provisions, ensuring that children who are exposed to violence can access effective emergency care and receive appropriate psychological support once it's identified. Education and life skills, making sure that children attend school, provide life and social skills training. These are all tools that are strategies that can be utilized to help end violence against children. Don't forget that child abuse has to be in your differential. The diagnosis of most abuse is based on history. There are some physical exam findings that are common in abuse that you want to identify early, and it is your legal responsibility to report any suspected abuse cases, and you must educate parents to help prevent child abuse. We now want to switch gears and talk about elder abuse. The definition of elder abuse is physical or psychological mistreatment, neglect, or financial exploitation of older adults. This is a video I want you to watch that shows some examples that you might not recognize or that people may not report.
Well, you can't. She's just not up to seeing visitors today or tomorrow. Well, it's just not possible. She's not seeing anybody, and she doesn't want to see anybody. No, not even you. You'll just have to wait until she feels better.
Ed, come here. I want that. Ed!
Now she's up again and calling me. I have to hang up. I'll call you soon when she feels better. Listen, Mom, you're just not in a position to have visitors right now. Maybe once you sign the documents, you'll feel better.
But I'm feeling fine.
Mom, we both know you'll feel better once you sign the house over to me. I just don't want you feeling overwhelmed with the burden of the house on your mind. All right. You might as well just go to your room then. Because we have nothing else to talk about until you sign. And you're not seeing any visitors until this is sorted out.
These things.
Here, let me do it. What's your PIN number?
1970. Your birth year.
Hi, Gloria.
Oh, hi, dear. How are you doing?
It's not working. We'll try again tomorrow.
But Mom, you had money in your pocket.
Come on, I don't want to hear about money we don't have. Let's go. Come on, let's go.
Mary, I'm hungry. Are you on your way out to the store again?
Oh, hey, guys.
Oh, Phil, you're back. How was school today?
Oh, there's no school today, Gramps. Just practice.
Okay, I am on my way out. Dad, you stay comfortable. I'll grab some food and bring it back later.
But, Mary, I'm hungry now.
You'll be fine for a little bit, Dad. I'll hurry, okay? Can you get your grandpa a glass of water and take him back to his room? Here, Dad, make sure you take your pill today, too, okay?
I thought I already did.
No, and you missed yesterday, too, so just take a couple of extra. He'll be fine. He just needs a nap.
What'd you say?
Nothing, Dad. You make sure to have a lie down. Okay, I'll see you guys when I get back.
All right, come on, Gramps. Let's go. Almost there, Gramps. Almost there. All right, and... Oh, yeah, there you go. There you go, Gramps. Let's go.
Wait, you're not gonna just leave him like that, are you?
He'll be fine.
I don't know, man. That just doesn't seem right.
He'll be fine. My mom gave him something that's gonna help him sleep for a while. Come on, we're gonna be late for practice.
You know what? I just remembered. I gotta go home first and get my cleats. So I'll just meet you there, okay?
Okay, yeah. Yeah, I'll see you there.
Okay.
Now, you can see examples there that are concerning, and you can see that people don't want to report the abuse. Fewer than 20% of abuse cases are reported, and only about 15% of abused older adults seek help from authorities or providers. And 1 in 10 older adults are victims of physical abuse, psychological abuse, sexual, financial exploitation, or neglect. Risk factors for the victim include for elder abuse include impairment due to chronic disorders, functional impairment, cognitive impairment, so dementia patients, those with difficulty communicating or social isolation. And for the perpetrator, there may be substance abuse or psychiatric disorders, a history of violence, stress, or dependence on the victim, such as a shared living arrangement. A 75-year-old woman comes to the emergency department with her spouse because she fell in the shower. The husband says that the wife used to be highly functional and independent, but her function has declined over the past year. He answers all the questions for her and appears overly concerned about her health and functional status, but when he's asked to leave the room so that the patient can be examined, he refuses. Her appearance is unkempt and her clothes are dirty. While discussing the management of the patient's clinical situation, you offer home health and the husband refuses. This is a common case that I've seen in my practice. I had an episode where a patient's husband was very concerned about her health. He brought her in many times to be examined. He was concerned about her vaginal pain, and at that time he felt that the pain was so severe that he placed the Vicodin that she had been given for pain inside her vagina. And it wasn't that this patient didn't, that her husband didn't care for her. It was that he didn't have the ability to care for her. I've had other situations where the caregiver comes in asking for pain medication, even though the patient says that they have no pain. That's a red flag. We've also had patients where you can tell that it's obvious that there have been financial abuse, where the caregiver is asking that the patient be deemed incapacitated so that they can make financial decisions for the patient. Those are all red flags. Physical or sexual abuse may come as bruises, puncture wounds, fractures, cuts, or burns. There may be poor hygiene or soiled clothing. There may be loss of hair in clumps from the hair being pulled. There may be obvious signs of dehydration. The patient may be without their eyeglasses or hearing aids. You may see injuries from restraints. There may be genital or rectal bleeding or evidence of excessive drugging, like in the video we saw. The patient was given multiple sleeping pills so that they would just sleep for the rest of the day and not need care. You see that abuse in nursing homes as well, so that's something to watch for. There's a lack or delay in seeking medical attention. Those are all signs of physical and sexual abuse in the elderly. Psychological abuse, there may be threats or insults or verbal abuse, refusal to allow travel or church attendance, like we saw in the video that the caregiver wasn't allowing family visits. Financial misuse of funds, we saw in the video how the person literally takes the money out of the debit machine and just puts it in her pocket. The mother's not aware, so that's something that can happen We also see where the caregiver asks that, again, the patient be deemed incapacitated or there's a change in will. Neglect is the most common form of elder abuse, and it's a failure of a trusted person to protect an older person from harm or provide for their needs. Self-neglect is also common, so it's something you need to watch out for. Red flags, previous history of abuse, conflicting accounts of accidents, unwilling to agree to treatment, inappropriate defensiveness from the caregiver, or failure to allow the patient to respond for themselves. History, the American Medical Association recommends that all patients are screened for elder abuse. That way it normalizes it. You tell the patient that everyone is asked these same questions. If elder abuse is suspected, the patient should be interviewed alone for at least a portion of the exam. And then if the abuse is confirmed, you want to make sure to document the nature, the frequency, the severity, who is involved. Try to get as much information as possible. This is a screening tool that can be used for all patients. Again, you want to normalize it. Let the patient know that everyone is asked these same questions so that it takes away, the stigma. Physical exam findings, some of which we've talked about. The patient may be appearing withdrawn. There may be evidence of that they're unkempt, that there's damage to the inside of the mouth, there's pressure ulcers that shows neglect. There may be the traumatic alopecia where the hair has been pulled and ripped out of their, off the scalp. Contusions that may suggest that they have been hit by a belt or a stick. There could be rectal or vaginal bleeding. There may be ligature marks on the ankle or wrist. And then there could be previously undiagnosed fractures, like they come in with a wrist fracture and now there's a clavicle fracture. And they may show new evidence of depression or anxiety. A laboratory evaluation should be completed to include electrolytes to determine any risk for dehydration, as well as an albumin to determine nutritional status. And you want to check for drug levels, just like we saw in the case where the patient was being given too much medication. There's also situations where the patient isn't even being given their prescribed regimen. So you want to make sure to evaluate those concerns. Documentation, this is important for child and elder abuse. You want to have a complete report of the actual or suspected abuse. You want to try to place this in the patient's own words using quotes. You want to have a detailed description of the injury, which should include photographs, drawings, x-rays, and any laboratory evaluation that you had. Intervention, if the patient is in immediate danger, you may consider a hospital admission. You want to contact law enforcement and consider relocating the patient to either a safe home or temporary nursing home for care. Examples of intervention include providing medical assistance, making sure you provide culturally sensitive education, trauma. You want to provide psychological support, whether it be short-term or long-term, to care for depression and anxiety. You want to have law enforcement and legal intervention, which can include arresting the perpetrator or having an order of protection. You also want to consider alternate housing, like maybe short-term nursing home, like I discussed, and then referral to support services such as transportation or food assistance. Reporting. All states require that suspected or confirmed abuse in an institution be reported. Most states require abuse in the home be reported. Florida is a mandatory reporting state. If there's any abuse, neglect, or exploitation of a vulnerable adult, you must report. These are the references included, and I want to thank you for your time today.